Hello, I'd like to welcome everyone to today's webinar, Stories of Compassion, Caring for People Experiencing Homelessness. I'm Stephanie Adler-Yuan, Director of Education and Training at the Schwartz Center for Compassionate Healthcare, and your moderator for today's session. The Schwartz Center for Compassionate Healthcare is a national leader in the movement to make compassion a vital element in every patient-caregiver interaction. Before we begin the formal presentation, let's go over a few details about the webinar. The Schwartz Center Compassion in Action webinar series is funded in part by a donation in memory of Julian and Eunice Cohen. Today's program will be 60 minutes long. The first 45 minutes will be a presentation, followed by a 10-minute question and answer session. Today's program is being recorded and will be available on the Schwartz Center's website 2 weeks after the session. Please note that as attendees, you are participating in listen-only mode, but can interact with the speakers by using the questions pane, which should appear on your screen. If you have any questions, please just type them into the questions pane and send them to us, and we'll address as many of them as we can at the end of the presentation. Finally, as you exit the webinar, you'll receive an electronic survey that we ask you to take a minute to complete so we may capture your assessment of today's program. Your feedback is important to us, and we read all of the surveys, so please be sure to fill that out. And now, it is my pleasure to introduce my dear colleague and our host for today's session, Dr. Beth Lown. Dr. Lown is an associate professor of medicine at Harvard Medical School and chief medical officer here at the Schwartz Center for Compassionate Healthcare. Welcome, Beth.
Thank you, Stephanie, and good afternoon, everybody. Thank you for joining us for our 2018 Compassion in Action webinar series. For those of you who may not know about our very unique and prestigious award, we do give the National Compassionate Caregiver of the Year Award, which is a national recognition program that elevates excellence in compassionate healthcare. Since 1999, we've honored outstanding healthcare professionals who display extraordinary devotion and compassion to caring for patients and families. The award is designed to be much more than recognition for the individual honorees. The goal is really to showcase best practices in compassionate care and to elevate compassion to a core value of our healthcare system. This year marks the 20th anniversary of this inspiring award, and as part of our celebration, we are featuring past finalists and recipients in our webinar series. Today's presentation, Stories of Compassion, Caring for People Experiencing Homelessness, will be presented by Compassionate Caregiver of the Year finalists, Jerry Mullen and Rosanna Means, who will share insights from their decades of providing compassionate healthcare to the neediest among us, people experiencing homelessness in the greater Boston area. We'll learn how healthcare has evolved to meet the complex medical needs of this population, and we'll hear about their experiences working with people who are experiencing homelessness. We'll bear witness to instances of exceptional compassion and to the rituals and practices with which Jerry and Rosanna have honored their patients in life and in death. And now I'm very, very happy to introduce today's speakers. Dr. Rosanna Means is the founder and president of Healthcare Without Walls, formerly Women of Means, which is a nonprofit organization of volunteer physicians and staff nurses who have provided free medical care and care coordination for homeless and battered women and families since 1999. Rosanna is also Associate Professor of Medicine at Harvard Medical School and a primary care physician at Brigham and Women's Hospital. Welcome, Dr. Means.
Thank you, Beth. It's a pleasure to be here.
Also with us today is Jerry Mullen, who has just recently retired after 2 decades as a nurse with Boston Healthcare for the Homeless. And Jerry has a very long history of caring for the neediest amongst us from the earliest days of her career as an ER nurse in Hell's Kitchen. So welcome, Jerry.
Thank you, Beth.
So we're really eager to start today's presentation, so I am going to turn this over now to Rosanna to launch us on our discussion.
Thank you, Beth. I'm really honored to be here and to be able to talk to people out there in the webinar world about the work that I've been doing for so many decades. Why is it so important to talk about homelessness and caring for homeless individuals? Well, for one thing, as a physician, I've watched the healthcare costs rise in this country. About 18% of our GDP goes to healthcare, and a lot of that is for taking care of chronic diseases. We have an aging population, and there are a lot more out-of-pocket costs for people. And also, it's important to know what I've observed in the healthcare system, that it feels like it's broken for everybody, not just vulnerable populations. Spending over 35 years as a primary care doctor, I've been seeing the rising of bureaucracy, cutbacks in coverage, confusing rules, people having to parse their medications in order to be able to take care of themselves. So there's an enlarging gap between rich and poor in this country, and my interest is in homelessness. From a 2014 report, we learned that the US poverty rate is 14%. That's 43 million people who are desperately poor. The number of requests for emergency food assistance have gone up dramatically, and in some cases, they cut back the portions in order to meet the demand. Homelessness itself is increasing. There are now, by most standard accounts, 1 million people who are homeless, and that also includes 2.5 million children who are homeless. The worst hit are families and women over 50. The number one reason for homelessness has been lack of affordable housing, and that's across the country. In fact, in this report, 22% of requests for emergency shelter were unmet. In addition, there are growing numbers of housing insecure, one paycheck away from homelessness. In many parts of the country, it's hard to make a living wage. In Boston, in the count that was done last year in January and repeated across the country, we found that there were nearly 7,000 homeless in Boston, and about half of those are women. The numbers are rising for certain portions, older women over 50 and families. And for the past 3 years, 25% of requests for shelter are unmet. We also have learned that women are undercounted. It turns out these national and statewide counts only count people who are in shelter beds or in transitional programs. They don't count people who are living in a doubled up or unsafe situation or staying in a safe house. And that's important when we think about the women, because a lot of the women that we see are staying in these doubled up situations or motels or staying with a batterer or staying on the street. So that's an important consideration for us. When we think about homelessness and how it affects healthcare costs, here are some of the factors that are involved. People who are homeless don't necessarily go to primary care, and so they use the emergency rooms for primary care or for urgent care. The people that we take care of who are homeless have a hard time connecting the dots, trying to navigate the system and figure out where they need to go, when they need to go, how to access their primary care doctor when they don't have an appointment, how to call for refills. Even when they have insurance, which is usually Medicaid or Medicare, and have a primary care, that's often not enough. In some cases in Massachusetts, if you don't select a primary care provider, Medicaid will select a name for you because you have to have a primary care provider's name on your card. Well, that might not be somebody that the woman knows. There are just too many holes in the safety net in terms of where you have to go to get your survival needs met, how to access primary care, especially if you don't speak English as your first language. And despite many resources in Boston that are there for the homeless, the cost of the care is still enormous and rising. 30 years ago, while I was working in a government-supported program for the homeless, I noticed that fewer women were using these programs than were actually out there. And it made me start thinking, where were they? And what were they doing for healthcare? And how could they be reached? I've since learned that there are different kinds of programs that care for women and men. There are homelessness prevention programs that try to get people into housing first and then provide wraparound services. There are government programs like the one that I was in, which is a parallel system of care that provides excellent care, but puts all homeless people under one roof. And then there is the rest of the people sort of fall through the cracks. They're out using the shelters, they're out wandering the streets, they're moving from place to place to be safe. And it's sort of a catch as catch can. And the safety net has been falling apart. So for that reason, I decided 20 years ago that we needed to find another program, a program that would bridge the gap between the life of homelessness for the individuals that were not in a specialized program and the healthcare system that really wasn't meeting their needs. And so that's when I come up with an idea of creating a program that we call Bridge Care. Now, Bridge Care is a program that involves the social determinants of health, and many of you are familiar with these terms. These are things that you need in your life in order to stay healthy. You need to have a home. You need to be able to eat. You need to eat healthy foods. You need to be personally safe. You need to be able to get from wherever you are to your appointments. And you need someone to help you connect the dots to interpret what's going on in the healthcare system for you. But what are the realities? Well, the realities are that a housing application is really daunting. It's sometimes there's so much information that people have to fill out that they have to apply more than one time. It's a daunting process. They have to go to the housing offices and fill out these forms. And if they don't have someone to explain it to them, they might be turned away. The food sources for people who are experiencing homelessness are sometimes erratic. If they qualify for food stamps, which is SNAP, they can get a certain amount, but that's all regulated by government formulas. They can get food at food banks if they can get to the food bank. They can get meals at drop-in shelters if they want to go there. They can get WIC if they're pregnant. In some cities, Boston has some programs where they deliver foods as a medical prescription, but it's not always consistent. And many times the food stamps don't cover a growing family. The food in the shelter is only one meal and they have nothing left for the rest of the day. In terms of personal safety, we know that over 90% of women who are homeless have experienced some form of traumatic event before becoming homeless and definitely after becoming homeless. And that includes physical or sexual assault, emotional abuse, verbal abuse. And it's very difficult for the women to feel safe, even in some of the shelters, if there are men in the shelters who have a reputation for abusing women. So women who are homeless very often will choose not to stay in a shelter because they don't feel safe there. Transportation is also a challenge for people, even though we all know it should be there. In Massachusetts, you can take public transportation. You can sign up for the ride, which is handled by the Massachusetts Transportation Authority. Your Medicaid card allows you to get something called a PT1 form filled out, but those all have pitfalls that don't make them necessarily reliable. And so sometimes the main thing that keeps someone away from getting good health care is the fact that they just can't get to the doctor's office. And often there just isn't somebody in their life that can help them connect the dots. This is a picture of somebody who slept on a heating grate in downtown Boston during a snowstorm. Obviously, this person is not going to be able to get up and navigate their way to their medical appointment. This is a person sleeping on the church steps, in the basement of which we have a shelter clinic, and that's their cart they've covered with plastic to protect them from the elements. This is a patient of mine that I see regularly in the shelter. She's 79 years old, and even though she belongs to our program for elders, and she had her prescriptions delivered in a blister pack. She took them all out of the blister pack and she divided them into morning pills on the left and evening pills on the right. That would make sense to her because she carries these 2 bottles. But unfortunately, what you can see is that she's taking some of her morning pills, but she's not taking her evening pills. This is a woman who came into our clinic and obviously had to be beaten up. So individuals like this woman live in constant fear. They're not thinking about planned and preventive care. So why do we pick on women? Why do we want women to come to our clinics? Well, the official counts leave out so many women, as I mentioned before. And women have unique biological needs. They need to be connected to the healthcare system. And finally, women don't necessarily identify as homeless. It's a point of shame and embarrassment for them. They won't say to a provider, I'm homeless, even though they're couch surfing. If you actually ask them, are you homeless? They'll say, oh yes, I stay at my friend's house. But they wouldn't say that they're homeless. And some of them just don't feel safe around men. I'm not saying that all men who are homeless are dangerous, but there are some in the shelters who are not safe for women, and the women choose not to stay in the shelters, and therefore they need to have a safe place where they can go. So our program involves nurses who are paid and community health workers, outreach workers who are paid, and volunteer physicians of a variety of specialties who come into our shelter clinics 5 days a week and also in our outreach programs and provide care in these safe places where the women go to have their survival needs met. So these are what we call social service intersection points in the shelters, on the streets, in soup kitchens and safe houses. We have predictable schedules and we encourage them to walk in so we can always be available. We are an NGO, we're a non-government organization. We don't have a billing structure. We don't have fees or co-pays. We have minimal bureaucratic hurdles. And we're able to connect our clients with their mainstream caregivers and agencies and specialists. And we are the communication hub for them. So if they see their primary care and then there's a problem with a test result or they need to come back, their PCP can contact us. More importantly, our care is very personal and it's unhurried. We treat them as if they are our own mothers or sisters or grandmothers. We actually meet them where they are, and it's very important that we take them at their word of where they are functionally and emotionally. Very briefly, I'll tell you a story about a woman named Mona who we met when she was in her early 50s. She suffered from serious paranoia and schizophrenia. She lived on the street, and yet she dressed impeccably. She always looked beautiful, and she wore a lovely turban on her head to keep her hair in place. Her main medical problem was that she suffered from cellulitis. Her legs were always swollen and infected, and it took us a long time to convince her to elevate her legs when she came into the shelter. She refused all formal care. She didn't have a primary care provider. And so our team of nurses and doctors and a psychiatrist and the shelter staff worked very carefully, baby step by baby step, to help her build trust with us, including going out on the street, sitting on the sidewalk, and having a cup of coffee with her. One day she explained to us that she had a growth on her scalp, and she was worried that the federal government was going to be reading her thoughts. And she wanted us to help her remove that growth on her scalp. And isn't this wonderful that I could do this? I called a surgeon friend of mine, and we arranged a visit during lunchtime when nobody would be there. We drove her out to the hospital, to his clinic, and we took her in. We didn't even have to register, put down her name. He didn't ask her any embarrassing questions. He just took her into the office, took off her turban, cracked a few bad jokes, made her laugh, removed this little growth, cauterized the wound, put her turban back on. We drove her back to Boston and left her with her cart on the street corner where we had picked her up. A few days later, she came back into the shelter and she was beaming with a big smile. And she said, guess what? I've been rebirthed. And we said, well, what happened? She said, that doctor took away all the evil out of my head. Well, after that, she agreed to get care. We were able to connect her to a primary care provider at the Brigham and Women's Hospital. She took her antipsychotic medications. She started being treated for a heart condition. We were able to get her housing. We were able to connect her with her daughter that she hadn't seen in years. And eventually, she stabilized and had a very happy life. Sadly, she died of a heart attack when she was only 57, just a few years later. But here's the thing. She was in a bed. She was with her daughter holding her hand. She was not on the street. She was not frozen in a corner. And she was able to be blessed by her daughter before she passed away. So what I'm saying is, we provide a community of services within a community of vulnerable individuals. We meet the women where they feel safest and are getting survival needs met. And we do this in the places where they are getting care. They're women's shelters, family shelter, domestic violence shelters. We're able to provide acute and urgent care, chronic disease management. We make referrals. We can do point of care testing, strep test, pregnancy test, urine test. We're preventing a lot of emergency room visits that way. We do asthma treatments, lots of diabetes care, wound care, foot care. Our community health workers provide personal accompaniment to appointments so they don't get lost. We stock our clinics with over-the-counter meds so they don't have to worry about finding these things in a pharmacy and not be able to pay for it. We can write a few prescriptions. And most importantly, we have no time limits. We're not pushing them out the door after 8.5 minutes. We love to share what we do with our students. We have medical and nursing students coming through the program and medical residents. This is a picture of one of our dermatologists who's been with us for about 10 years, providing exemplary care to our women. You will notice that she's in a closet. We don't really care where we provide the care as long as we can provide it. This is a picture of us and one of our nurses out in the street talking to a woman who was terribly paranoid and had many, many medical issues, a lot of self-mutilation. She is now doing fine. She's in a mental health program, housed and taking medication. Here I am doing foot care on a patient. We learned very early on that doing a blood pressure was not always safe for the women. If you put a blood pressure cuff on somebody and pump up the cuff, for anybody who's been held down in bondage, it can be very scary. So we learned how to cut toenails and do foot massages to build trust and to take away that fear. Here we are in one of the family shelters doing a health fair, teaching the moms about healthy food choices. The adjunct to our care teams are our field teams, and these are comprised of community health workers and nurses who do care coordination, address housing and benefits, accompany the women to medical appointments, as I mentioned before, and do home visits once they're there. All of our community health workers address the social determinants of health. We have 2 Bridges programs, Bridges to Elders for women 60 and older, and Bridges to Moms for women who are pregnant and postpartum. This is one of our doctors checking the teeth of one of our Bridges to Elders women, and this is a woman who finally got her apartment after many years on the street. The cost savings for Bridges to Elders is phenomenal. 86% drop in emergency room visits, 77% drop in inpatient stays. This is a woman in our Bridges to Moms program, and this is a partnership with the Brigham, and this woman had a baby at 27 weeks, 1.5 pounds. This is the baby at 1 year after she was housed. And here is the mom who graduated with her GED last December. So a big success story for somebody. In our Bridges to Moms program, we're able to show an 80% prenatal clinic attendance rate, and shorter NICU stays. 90% of the NICU time is spent with the moms visiting the baby and bonding, which means less foster care. We've been able to improve the housing from 10% at referral to over 60%. We do this by providing CAV vouchers for every appointment and every NICU day. We provide meal vouchers so the women can get a healthy meal when they're at the hospital. We encourage solid birth control methods, so over 90% of the women now are on birth control after birth, and 91% have connected to primary care. The self-actualization is really important so that we encourage women to get GEDs and to take skills to learn new skills and to get certificates, and we give them gift cards when they reach those goals. So the future of medical care, as we see it for vulnerable populations, is looking at the big picture. We need specialized care services for homeless individuals, but we also need to look at how we give care in the community to prevent people from falling through the safety net. And what we do is go to multiple patient-selected locations with an embedded care team as facilitator, communicator, and coordinator between the shelters and the hospitals and the health centers and the primary care providers. We also have the field teams that address social determinants of health and accompany the women to appointments. In this way, we're changing outcomes for vulnerable women personally and compassionately. Now, to end with, I'm going to tell you a quick story about a woman that was very personal to me. Her name is Judy, and she actually was videotaped by the Schwartz Center. After I was picked as a finalist, they interviewed her as a patient of a finalist, and she did an absolutely fabulous interview. Well, Judy came to this country from Australia as an interpreter for the UN, and she ended up having her life unravel due to untreated mental illness. She was actually on the street for 25 years. She was bipolar, mostly manic, but she was at the same time extremely entertaining. She could quote Shakespeare by memory, and with her Australian accent, she was actually really, really convincing and really entertaining. She was hilariously funny. She was what we would call a character in the homeless world, but at the same time, the tragedy was that she neglected her health. She refused any formal health care. In fact, I was basically her primary care provider, even though that was not my official role. But she did agree to episodic care. When I first met her, she was living out at the airport, and that was before 9/11, where people could stay at the airport and nobody really noticed them because there were always people in the international terminal late at night and all during the weekends. She self-medicated her mood changes with alcohol, and she smoked 4 packs a day. Well, one day, about 4 or 5 years ago, she got terribly sick, and she needed surgery, and she was a very high-risk surgical candidate. We found a surgeon who would take her, and she went through the surgery and survived the surgery, and I spoke to her afterwards, but she had many complications, and 2 weeks later, she died. We were with her when she died, and we searched very, very far all throughout Australia. We called the Australian embassy. We tried to find any living relatives, and we couldn't find anybody. So we took on the task of arranging her funeral. We worked with a local funeral director. We had a funeral for her. We played the Australian national anthem. We dressed her in her favorite outfit, which was a sequin dress with a feathered boa. And after the funeral, we had her cremated. In fact, her ashes sit in my office still, along with the Australian flag. About a year and a half after Judy died, I was going to Nepal to do some community service, and I wanted to honor Judy. So I took a handful of her ashes in a little baggie, and I went out to Logan Airport to the international terminal, and I walked into a bar and ordered a glass of wine. And I spread Judy's ashes under the seat next to the table. And when my wine came, I raised the glass to her and said, "God bless you, Judy. May you rest in peace." And so that's the story of Judy, and that's the story of what we do for the women that we care for. We care for them tenderly and personally. We care for them as if they were our own mother or sister or grandmother. And we feel incredibly blessed to be able to do this work. And so now I will turn the microphone back to Beth. Thank you so much for listening to me.
Thank you,
Thank
Rosanna.
you.
That was so incredibly moving and poignant, and the stories are so powerful. So thank you for the work that you do. As we're about to turn the conversation over to Jerry, but as we do, we'd like to just share this wonderful video about the impact her care had on only one of her patients, and we hope you enjoy this brief video. It may take a few seconds to load, so be patient and keep in tune with us. Don't go away. So let's now hear a little bit from Jerry. Now that you've seen from one of her patients exactly what her work is like. Jerry, I don't know if you want to reflect on the video or if you want to just tell us actually before we get started about this particular patient and what she's doing now, and then we'll move on.
Well, Joanne is an extraordinary example of someone who has worked through so many horrendous childhood and later life experiences, and she's just an amazing woman, in my opinion. Right now, she works with the Consumer Advisory Board at Boston Healthcare for the Homeless, and she also has spoken at the National Homeless Conventions and in sharing her stories. And she's a wonderful advocate for other homeless patients. She's done an advocate booklet of things that homeless people need to know, and it's really extraordinary what she's done with her life. I'm so proud of her and so grateful to know her, and she's been a tremendous gift to me in my life.
Jerry, you want to talk a little bit about what drew you to this work in the first place? Maybe speak a little louder.
Okay. Oh, okay. I first became became a nurse in 1968, and I rotated through the hospital in New York City that I trained in, and then I ended up in the emergency room, and I was so shocked to find that when I'm in the emergency room, patients would be many women would be being brought in at night, evening shift, and with these massive leg ulcers and, very oftentimes assaulted, falls, and just some terrible things. And I was so surprised that older women were out like this. Oftentimes the patients would be talking to their voices, or, you could tell there was some degree of mental illness. And myself and some of the other ER nurses, we did a lot of research, and we realized that this was almost like a public health crisis back then, that the federal cutbacks in the early 1970s forced the state mental institutions to release thousands of chronically mentally ill patients to the streets. And the plan was they were to receive housing in single-room occupancy hotels and then go to aftercare clinics and get their meds. But that part of the program did not come through to them. And these poor women just roam the streets, living in and out of Port Authority. For New York, it was Port Authority Bus Terminal, the Grand Central, and Penn Station. And what happened is, as a new nurse in a Franciscan sister, we were encouraged to really go back to the spirit of our founder, the Franciscans, and to live very simply and just be in tune with the people who are in need or poor or in need. So it caused the four of us young sisters who had just graduated to really focus on what can we do to make a difference. And I realized that the same thing was going on in Boston, which was my hometown. And at that time, Kip Turner, the founder of Rosie's Place, was working on opening Rosie's. We learned that Dorothy Day was down in the Bowery, and she was opening Mary House. So we thought we need a place uptown to catch these numbers of homeless women who are in the street. Our first step was to live in a tenement apart from the convent so that we could experience the need of what was going on, live a little simpler lifestyle. So we got permission to do that. And I remember looking out the window one of the first days I was in the tenement and seeing a woman going through the trash out front. And I thought, wow, we just need a building right away for these women. One of the other things I learned in the ER is sometimes the doctor would see the patient and advise, well, you can go back and just take antibiotics and rest and elevate your feet. Well, I investigated this is back in the 70s, and there were only 18 beds for homeless women at the Bowery shelter, whereas there were hundreds for men. So that showed us that there's just such a need for another shelter here in New York. So we did get permission. We opened the Dwelling Place of New York, which is still open today, 40 years later, for women, and has met a great need, but certainly not enough. It's still as you can see, still such a great need. And as Roseanne pointed out, homelessness is just so difficult. There's so many facets to homelessness that to be on the street, you just need a home to be healthy and safe and to live your life. A couple of stories that I have is what I learned early from the ladies. We went out and what we did was do outreach. Before we opened the shelter, we said we went out and tried to make friends with the women, spending time in Port Authority, Penn Station, and Grand Central, and especially at night, to try to build trust and to ask them what they would want if we could open a shelter and get a building. And over, these women would tell us, we just want a place where we can do our laundry, get our clothes dried, sleep, rest, eat, put our feet up, just the basic human needs. It was really such an eye-opener for me, and I was just so struck at how caring they were of us who were coming out and hanging out with them at night. One lady I'd like to share about is Kai. Kai was a woman who sat in a bunch of boxes. Winter and summer, I had seen her for a whole year when I was living in the tenement initially, and I couldn't believe how she would just sit there smoking cigarettes and talking to her voices, and just would be there winter and summer. I noticed how her fingers she lost the tips of many of her fingers from frostbite. She was in just, such a difficult situation. And when we opened the shelter, we told her we were going to open. We said, please, would you like to come? We'd love you to come. She never gave a commitment to come. We opened and she didn't come. And it was getting close to winter again, and the police were worried because she sometimes would build a little fire in a can, and they were afraid the boxes would ignite. So one night, and the police were very open to our opening the shelter and wanting to help us because the ladies were in such terrible straits on the streets. And so one night the police came to the door and said, we have to break up her boxes and tell her she can't be here because on the street, because it's just so, on the sidewalk actually, it's so dangerous. So within minutes, the doorbell rang again, and there was Kai standing there. She wanted to come in. So I welcomed her in, and I said, we have a bed, and she said, no. She just wanted to sit in the corner in the dining room. And I realized because of all the years she had been sitting on the boxes, probably had contractions now, I think, that she could barely even walk, let alone lie. So she wanted to sit in the corner. So we got pillows and put them around her, and she just sat there, and I don't know, it went on for almost like a month because it was so difficult for her to engage with other people, and she just felt comfortable in that little corner. So we let her stay there, giving her her food and all that. One of our volunteers had a social worker background, and she spent hours with her just talking, trying to listen to what her voices were saying and all that. Come to find out, this beautiful lady was a waitress in the exact same part of the sidewalk where she built her boxes. And it was in a diner, and she worked there for years. And what happened is, when the Port Authority was renovating in the early 70s, they took the diner and demolished it. And so poor Kai lost her job, her whole life, and her mental illness, we assume now, spiraled out of control, and she just, set up her boxes there because it was the only place she knew. The only thing she ever said about her family was her parents were missionaries in Africa. But so later, I after a fashion left the sisters and the dwelling place. But Kai came back to visit about 5 years later. We had gotten her from the shelter into a housing, and she was at St. Francis House, run by the Franciscan Fathers, a new shelter in that era. And she did very well there. She ended up going to Bellevue, though she had cancer. And then she came back, and she was on meds when she came back to visit the shelter. They have a program where every Wednesday night, anybody who's ever been part of the shelter comes back for dinner or just for fellowship. And she came back and wanted to thank everybody, told the sister that was there then. This was 5 years later. This would have been like the mid-'80s. That she wanted to, thank everybody. She was doing good. And then later we heard that she just died of natural causes at the shelter. So it just pointed out to us, though, how, and I've heard it, learned it over and over so many times that, given a chance, people can turn lives around. It's just amazing. The other thing I'd like to just share is, so a couple of other stories, just that to show the beauty and depth of the patients. One story is I'll share about two patients, Dave and George. They were in I'll just, not to backtrack, but coming from New York, then just, I left the convent because of my sister-in-law, my beautiful sister-in-law at age 33 died of cancer. And she left a little 2.5-year-old boy. And so when that happened, and I had been going to help her while she was ill, I just knew I wanted to leave the convent and leave the shelter and go back to be a part of my nephew's life, which I'm so grateful that was all made possible. And then there were other family concerns of my parents being ill and that. So what happened is, I'm sorry, I just got distracted. For a period of time when my nephew was growing up, I volunteered at Pine Street because I was back in the Boston area at Pine Street Inn, and I had such wonderful good fortune of being orientated by Barbara McGinnis, one of the pioneers in work for homelessness, who was at Pine Street Inn, and I worked the evening shift, volunteered in the women's clinic. I just felt like I learned so many wonderful things about compassion, compassionate care. One of the things that Barbara always talked about was to just give love. She said, and her motto was, as some of us will evolve in our lives to be healers, she said, she wanted to remind us that, and I found this oftentimes in my career, where when later, 20 years I've been with I was with healthcare for the homeless and just retired last November. That if we might have the attitude, you must be healed, that so often there's the message it's given. But I've learned that some patients don't need to be healed, as Barbara so eloquently said. And just give them love, and the soul will take that love and put it where it can best be used. So with that in mind, I'd like to share about Frank, who was a gentleman who was suffering with end-stage heart disease, and he needed a valve replacement, and he kept putting it off because he had difficulties with alcohol, and he would often run away after he was on miss his appointments when he was supposed to go in to see the cardiologist. So he had come to us from the street, came in with the outreach van, and he was really doing poorly. I came on shift at 3 o'clock, and I noticed how short of breath he was, and I called the doctor a couple of times. We gave him some different medications. We were trying to make him more comfortable, but it seemed like it was getting worse. Towards the end of the shift, I had spoken to the doctor a couple of times. He called back and he said, I really think, Frank, I know we all know how much he hates to go to the ER, but I'd like to, I really would like to try to get him to go to the ER tonight to Mass General. So knowing how Frank felt and understanding, too, from so many homeless people, they don't want to go to the ER. First of all, like you and I go to the ER, we might choose what we're going to take. They want to take all their possessions. It's very difficult. Sometimes they get thrown out, whatever. They very fearful to go by themselves. It's just a host of reasons why. So what happened is I talked to this young nurse who was on with me, who was 35 years younger than me, a brand new nurse, and I said, listen, I'm not sure how to go to Mass General, but is there any chance you could lead me over there? we'll send Frank in the ambulance, and then at the end of our shift, we'll tell Frank, we'll go, I'll follow you over. You'll show me where to park, and then I will stay the night with him. So this wonderful young nurse, Una, she said, sure, I'll do that. I know right where it was. I did a clinical there. So she went to, she led me over. And I go to Frank, tell him the plan, and Frank is all for it. He said, sure, I'll go, okay. And I said, so Frank, I'm going to send you in the ambulance now, and then we'll follow, come over, and then I'll stay for as long as it takes to get you stabilized, or if you had to stay or whatever, okay? So he said, he agreed. So we go over, the plan's in place, it goes smoothly, and we tell the people at the front desk at Mass General, we're here to see Frank. And so they said, okay, so they brought us down to this end room in the emergency room, and we start to walk in, and there's two doctors seem to be with Frank, men in white coats, and then there's the nurse, and she looks up and she said, oh, Frank, your wife and your daughter are here. Well, we burst out laughing, and then going in, looking at Frank's face, it was like he was just laughing so hard, and he said, oh, go home, you guys, go home, go get some rest, I'll stay, it's okay. And I think over and over I've seen that with patients. Sometimes, just like all of us, they just need a person to be in their shoes and just understand that how difficult things are for especially someone experiencing homelessness. Mm-hmm. I mean, when you think alone of the seasons, when you think winter to summer, each has its own list of horror stories with it, in the sense of like frostbite and the accumulation of frostbite year to year, and I've known someone who had to lose both legs because of that, because of frostbite, just advanced up their legs to these amputations above the knee. It's just awful. And then for summer, in summer, it's dehydration. It's not being able to hydrate because there's no public bathrooms or very little accessibility to that. It's just rashes and itches and sunburn, and just even if you get caught in the rain. If I get caught in the rain, I can run home and get some dry clothes. Homeless people can't do that. Mm-hmm. They have to live in their shoes and wet socks and over and over. So
there's so many stories that you have to share, yeah. Jerry. They go on, and they're so powerful and moving. We're going to wrap up in a few minutes, but before we do, I just wanted to ask this question. And Rosanna, maybe I'll start with you. If you had one thing that you could tell other healthcare providers about working with this population, what do you think that might be? What lessons would you like them to know?
I think that, thanks for asking that. And Jerry, thank you so much for your wonderful words. I work with healthcare providers all the time and try to teach them about what's going on. I don't think this current learning environment is good for them. They don't get a chance to see what happens when people walk outside the doors. And so if there's one thing I do tell them, it is to understand the kind of 4 questions we ask in the social determinants. Find out where your patient has come from. How did they get there? How are they going home? Do they have adequate food, and how do they nourish themselves? Do they have teeth to be able to chew their food? And are they personally safe? And if they could ask those questions, they could build it into their commentary with their patients, they would learn an awful lot about what's going on outside the walls of the hospital and health centers.
Mm-hmm. Thank you, Rosanna. How about you, Jerry?
I agree. That's so, those are really the essentials, Roxanne and Roseanne. I also I deal more with nurses, so sometimes I just say over and over, like, just let's put ourselves in their shoes. They walk such a hard road, and things that we just kind of roll with, like you're even saying, do you have enough food? Do you have dentist to eat? Do you, things like that. To just really be aware of, and maybe that can explain sometimes the behaviors that people are so agitated about. I remember so many times patients, if you do get them to go to the emergency room, maybe they've just come from the outreach van or something like that. When one thing that they hate to lose is a little bit of property that they might have. It means so much to them. So I thought of a way that we could have some extra padlocks, and I could assure them, listen, if you go and get checked out, I will lock up your stuff. And if you are not coming back tonight, if they want you to stay, if there's a real problem going on, then stay and get all the care and get cleared to come back. And I have a key here. I'll unlock your locker, and we'll put it down in the safe with the security department. So sometimes just little things like that help them, just like you're saying, Rosanna, that, just to make sure people have food and clothing and shelter, not shelter, but shelter definitely, but just the basics, and where homeless people or people living in homelessness just don't have it.
Yeah, so to think of the little things and actually to have a systematic way of inquiring about them, as Rosanna suggests, and also just to share the love that you feel towards these folks who are experiencing homelessness and just living day to day. Well, I want to thank both of you so much for participating, and I think what we'll do now is just turn this over back to Stephanie so we can close the webinar. But my thanks to both of you for the work that you do, for the service you provide. It's really an inspiration. So Stephanie, would you like to wrap us up here, please?
Thanks, Beth. And yes, thank you so much, Rosanna and Jerry. I can't help thinking, A, what phenomenal stories these were that you shared, and B, how much you inspire the work that we do at the Schwartz Center. So thank you for sharing that, and thank you for all you do. And thank everyone who's been on the webinar with us today. I hope you've enjoyed your time with us. And this was the third in our series of our 2018 Compassion and Action webinars, in which we've focused on the wonderful individuals like Rosanna and Jerry, who've been recognized with our National Compassionate Caregiver of the Year award over the last 20 years. And as I mentioned at the beginning, we know how busy you are, but we would really appreciate your feedback and the evaluation after the session. Our next webinar will be posted on our website soon. I believe it's July 9th that it's slated for, so save the date and look out for our email invitation. And have a fantastic day. Thank you for joining us.